They're typically not coming to say, well, I think my neck's a little stiff and I'm here for a treatment. They're usually because of pain, right? They're presenting to you because now they have pain and it's concerning and now they want some help, right? They're not coming in and say, oh, my neck is stiff, can you help me out? Do not do that. So I like to work in the clinic with a mirror here because I want to see their face, okay? If I don't have a mirror, then I'm gonna be in the front because I want to see her face, right? Because some patients will let you push them too far rather than giving you the information you need. Some people will grimace and never say a noise, and you might miss that whole thing, okay? Right, so components of motion, okay? The head has to move on the neck. So the occiput or the cranium moves on the atlas, T before X, right? Those are the things you kind of never forget from PT school. T before X, T before X, right? Right? So when I do that,
T before
it's atlas before axis.
A-T,
It's T, T.
Oh.
Keep up, dude.
I just knew atlas because like the word.
I know both.
Somebody didn't learn their
Okay.
alphabet.
So when you're looking at upper cervical spine, the OA joint, you get a little head nod, right? So that's that short neck flexion and short neck extension, if you will. So that's upper cervical. So a little bob of the head, nod, and then nod up, right? So that's the head moving on the neck, okay? The head also, the OA joint, does a little bit of side bending, just a little bit. So head on neck side bending, okay? Back here, head on neck. Just so you know, so if I had a patient that was here with neck pain with headaches, I'm gonna be very thorough up here, okay? If I have somebody with neck pain mobility deficits, neck pain with movement coordination impairment, neck pain with radiating pain, I'm gonna be more focused here. Does that make sense?
Mm-hmm.
But we still wanna look at all of it together, okay? So I'm gonna ask her to put her chin on her chest, so I want you, wait a minute. Right, so I just want you to nod down as far as you can and then bring your chin to your chest. I'm engaging upper cervical and now we're moving to middle lower. Any pain or discomfort with that?
No.
I'm gonna stabilize here below C7. I'm gonna come over the top. I'm gonna give you a little bit of overpressure. You let me know if there's any pain or discomfort or reproduction of your symptoms, okay? Can I go any further?
Yeah.
You okay? All right, so now I'm getting a nice, firm capsular end feel. There could be a firm muscular end feel, because a lot of us are tight back here, right? The difference is the muscular end feel is gonna have a little bit of give. The capsule is gonna be like stretching a leather belt or a bed sheet. When you get to the end, it's gonna be that abruptness. And then bone to bone is just really your terminal elbow extension, okay? I'm going to ask her to look over your right shoulder, if you will. Good, and back to the center, and then left. Okay, and then back to the center. So I'm getting a gross range of motion. Is it symmetrical? Is it asymmetrical? Is there any substitution? Turn your head over your right shoulder again. Okay, any pain with that?
No.
No, okay, can you leave it there? Can you relax? And I'm just going to take you further. Okay, so my hands are up here, not through the jaw. My hands are on the forehead. Okay. And I'm going to take you right to the end of the motion and relax. Any pain with that?
Nope.
Okay. Turn to the left. Okay. And then I'm going to come in this way. Right? So this elbow here is just preventing compensation. Right? So just slightly.
I like
that trick.
Yeah, I like
A little bit.
Where?
On this side.
On the left side or right side?
On the right side.
On the right side. Okay. Is that typical
Not so
or
much pain.
atypical?
I don't really
Stretch?
think about it. It was
Little
a stretch.
stretch.
It was a stretch.
Okay, different than the other side.
Yeah.
Right? Okay.
Prefer out.
Eval the shirt.
This is the wrong therapy, sorry. Just kidding, just kidding, okay? Then we can do side bending. I can have her touch her ear to her shoulder. Okay, any pain with that?
No.
Now watch where my hands are gonna be. They're not here. They're here. Because I do not want to do a muscle length test. I'm looking at cervical range of motion, trying not to draw in the upper traps. Okay? Any
But why
pain
on
with
that side? Because wouldn't she compensate by like bringing that shoulder up?
She could, but I would see that, but I want to see what the motion is right side bending. If I do this, what does that feel like?
Ow.
Right, you're gonna
Yeah.
stop the motion versus
Massive
this, touch your ear to
stretch.
your shoulder, and now I'm gonna give over pressure.
Okay.
Oh.
Touch this ear to your shoulder, any pain with that?
No.
Okay, and then I'm gonna come here and give some over pressure.
So is it almost like you're allowing like a little bit of like that tension in the shoulder?
I'm not worried about that.
So that way you can get a little
Correct.
bit more, and then okay.
Correct.
Okay.
Now, one strategy you can use if it's a lot of, is offload the arms with pillows.
Yeah.
Offload the traps, and then now you can really see
Give
the
a little
range
bit
of
more.
motion. That's
Put the
right.
strap on slack.
Okay. Yeah, put the strap on slack.
Would you also like cue them to kind of get more of a posture? Wouldn't it?
No, I'm
wouldn't
not
that-
cueing, I'm watching how they like to move where they're starting from,
Oh, okay.
right?
So like if they were already starting out slouched, then
I might just do that, and then I might say, okay, let's sit up a little bit now, and now turn your head to the, whatever painful direction. So let's turn your head to the left. How is that? How's
Better.
that? Better? Okay, and how about if I do this? Any discomfort there?
No, just stretch.
Okay, so I just change your posture. So I typically will, where they are, how they like to move, and then I'm trying to incorporate, if I change this posture, does it change the symptoms? We all have poor posture. You have to decide, is that poor posture contributing to the patient's symptoms? Okay, so we did side bending, rotation, flexion, now we need to do extension, right? Okay, extension, I'm very careful about. What are two critical structures that come through the cervical spine? Vascular. Vertebral artery. What are two arteries in the front that are in the cervical? Carotid, right? So I'm stretching, compressing, right? So when I get ready for extension, I don't do overpressure with extension. So I'm compressing the facet joints and also compressing the vertebral arteries, but I'm also stretching the carotids, okay? So I'm gonna have her look up towards the ceiling, okay? Any pain with that?
No.
Okay, and can you open your mouth now and look back? Open your mouth, there you go. Take the tension off of here, that's the weight of the head. The head is like a bowling ball, between 12 and 15 pounds. Okay, so just the weight of the head coming posterior is enough, for me, is enough for passive overpressure. Okay, I don't give, Dr. Reed, do you give pressure and extension? No, I don't either. I just use the weight of the head, and sometimes I'll guide. Okay, look up towards the ceiling as far as you can. I'm not blocking it, I'm just guiding it, right? Oh, that's a little painful, okay. And can I bring you out of here? So sometimes people need help to come out of that position.
Just want to make sure you said you never do overpressure on extension of
Yes.
cervical?
You're
The
stretching
weight of the
out your
head.
carotid.
Okay. That is a Donnelly bias, being clear.
All right.
And the bias is
Oh.
based on the structures that are being compressed, vascular structures that are being compressed or stretched. Okay? You will see it in the clinic, people do it, my choice is not to. I feel the head is enough of weight, and then if I have them open their mouth a little bit, it's gonna take this tension and the head's gonna fall back like a Pez dispenser.
That's a good analogy.
You're closing down neural structures as well.
Right.
And so most of your patients that come in with neck pain, you really don't wanna put them in a lot of extension ever, because you're just going to irritate what they come in for.
So remember, your facet joints are designed to bear between 10 and 15% of your body weight, or your head weight.
Literally my head.
Okay? So anything we move in extension, you're gonna be wapering on the articular cartilage and the meniscoid bodies within the joint. Remember, you get one dose of articular cartilage in a lifetime. It does not repair. You get one dose, be kind to it, right? Fluid film and boundary lubrication, low resistance motions, right? You wanna protect your articular cartilage at all costs, okay? Because you only get one dose.
So let's just say,
It's the 4th of July? No, I'm just kidding. Let's just say,
that hypothetically you have a patient and you do put them into slight extension just to like get started, and then immediately they do start feeling like some tingling or numbness.
where?
Like in the back of their neck or on the
Okay.
side of their neck.
So
then-
you tell me, what is that?
So, I mean, that sounds like a nerve, so then you.
Okay, so extension closes the intervertebral foramen and also narrows the central spinal canal. Flexion opens up the intervertebral foramen and the spinal canal. Okay, see how that works?
That would help with figuring out where to look.
Would you put them in the flexion?
So as soon as they get symptoms, I would note the symptoms and I bring them right out of the position. You're not letting them hang out. You are not saying, okay, can you stay there while I measure this with my goniometer? Yes, nobody's doing that. Okay? What if, when we did this, she complains of perioral numbness? or she has difficulty speaking.
Refer out
What are
speech.
those part of? The 5Ds.
Oh, yeah.
Dysphagia,
We're dealing with cervical spine.
Dyspnea.
We need to pay attention to your 5Ds and 3Ns.
And.
1A.
And
1A.
1A. What's the A now?
DNA.
I can't keep up.
DNA.
What is it?
Ambulation.
Oh, ambulance.
Oh.
Gait.
Come on,
Okay,
that's
okay.
That works.
I would call it gay, but anyways.
Option A and ambulation.
Yes,
DNA
okay.
makes
Right?
sense.
So that's what you want to be cognizant of, are weird signs. So double vision, dysarthria, diplopia, dysphagia, and drop attacks. A drop attack is a loss of balance without losing consciousness. So it's not syncope, right? They don't go out. They just, drop attacks are people just fall to their knees. Right? I don't know what happened, my knees just collapsed. And that's gonna be more indicative of cervical myelopathy or some vascular issue.
Is there a
okay?
medical term for that or no?
Drop attack.
That is it? Okay.
That's it, yeah. People will know it, doctors will know what that is.
Okay.
Okay? But remember, it's a cluster
Yeah.
of symptoms, okay? So that's active and passive. Everybody good with that? Okay, so now we're gonna do resistant. The key number one, resisted range of motion in the cervical spine is rotation. Why? What muscles rotate the head to the right? Muscles on the left and muscles on the right.
Yes.
Always bilateral,
Yes.
right? So if you look at your cervical rotation, left side, right side, okay? So if I do resisted rotation, I want you to hold your head here. I don't want you to overpower me, just meet my resistance, don't overpower me, okay? So I'm gonna try and turn your head to the left, you're gonna try and turn your head to the right, but if you just hold your head there, don't let me move you, hold, 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 and slowly relax. So I got a nice, strong, isometric contraction and right rotation, and no reproduction of symptoms. Painless
Yeah.
and strong.
I barely
Okay.
felt that.
I didn't even see you do
If it was,
I didn't see you
let's say,
move.
strong
I
and
thought you were just
painful,
squeezing her.
muscle tendon.
We're gonna get there, we're gonna get there,
Tendon.
okay?
Oh,
So
yeah.
listen and be very clear. Rotation is the number one. If it is strong and painless, we don't do any other motions. Because we have already incriminated muscles on both sides of the neck, okay? If I do, let's say, left rotation now, you relax.
Sorry.
You hold your head there, don't let me move you. So I got my hand on our occiput, this one's on the temporal bone by our forehead, hold it there, hold it, hold it, hold it, and slowly relax. So it has to be a pure isometric technique. If when she's relaxing, the head does this, oh, that hurts. What hurt? We don't know because we allowed the neck to move, so it could be joint or muscle, tendon. So it's a pure isometric contraction building up. Yes, it's a strong contraction, no pain, and now we gotta ease off of it with no aberrant motion, okay? So hold your head here, don't let me move you.
How much pressure are
Hold
you
it.
putting? Because it doesn't look like
It's
Not
not a
a
lot.
lot, yeah.
What am I trying to do? I'm trying to get the
Reproduce.
muscles to
Yeah.
contract. Not overpower. I wanna slowly get up to a strong contraction, and is it painful or not painful? Okay? So she's holding her head here. Hold it, hold it, hold it, and slowly relax. Hold your head here, hold it, hold it, hold it, and slowly relax. Okay? That's your active passive resistant. Okay, let's say left rotation was painful. Darn it. Now I have to do all the motions. Okay?
Nice going.
So I'm gonna have her, okay, so I'm gonna have her put her hand on her chest. I'm gonna put my hand over there. So I'm gonna try and push your head forward, and you're gonna push back for me. Okay, hold it, hold it, hold it, hold it. And slowly relax, okay? Then I'm gonna come here. I got my hand on her back, stabilizing. This hand here, I'm gonna try and push her head back. Hold it, hold it, hold it, and slowly relax. Okay? Side bending, hold it here, hold it, don't overpower me, hold it, and slowly relax. Patients will always try to overpower you. Hold it here, don't let me move you. Hold it, hold it, hold it, and slowly relax. Okay? So that's all of them. So we start with rotation. If it's strong and painless, we're done. right rotation is strong and painless, left rotation is strong and painful. And then I have to add flexion, extension, and side bending. Which muscle is it? Right? And then when we do more positional and muscle retraining, we're gonna teach you with lasers and deep neck flexor retraining, all those other things. But this is ruling in or ruling out a contractile element. Everybody good?
Yeah.
Okay? So you, yes, ma'am.
So if you do one side rotation and it hurts, and then you have to go through all the motions again. So let's say if you did the flexion and that one hurt, would you think it's like the cervical flexors that hurt?
So deep cervical flexors, so it could be longus colli, right? Which is the deep muscle here. Could be sternocleidomastoid, could be your suprahyoid muscles, could be your infrahyoid muscles, right? So how am I gonna confirm any of those structures is my palpation,
What
right?
if,
And trigger points.
so what if
Does it make
flexion
sense?
is like, what if you have pain in flexion, but also pain in extension, can that? So you don't just stop the test as soon as you, if you do flexion, it's positive, you keep doing it through all of
I'm
them.
jotting it down. Is the range of motion limited? Was it active or was it passive? Okay? Is it active or passive? Flexion, so the opposite of flexion is extension. Opposite of right rotation is left rotation. Opposite of right side bending is left side bending. Okay? So you have to think about every single component motion. What I'm saying is active and passive range of motion, limited and painful, same or opposite. Make sense?
Yes.
Okay? Right, so I want you guys to get in your pairs and threes, active range of motion, and then overpressure, every direction, okay? And then I want you to do resisted tests. Start with rotation, and then do flexion, extension, side bending. Good?
So you said you start with rotation, strong and painless, so you don't do the rest.
Correct.
You said if it's painful, whether it's strong, weak, what if it's weak and painless? Do you still do the rest of them?
So what do you think I'm gonna have to do then? It's weak and painless.
Yeah, no, because that's more.
Stop
So now I'm gonna have to do a manual muscle
MMT.
test. So I'm gonna have to do the beautiful neck flexors and extensors, an MMT. How weak is it? Make sense?
Yeah.
Okay. So if it's weak and painless, how weak is it? And then do I think it's a muscle issue or do I think it's a nerve issue? Or something sinister? Maybe there's a space occupying lesion, maybe there's something else. But I would have a lot of that information from the subjective exam, right? My constitutional science.
Just out of curiosity, why do you put her hand, why did she put her hand?
Right, so I'm stabilizing, so I'm not,
Appropriate.
right? No harm, no foul. My hand's gonna be on her hand,
Oh, I see.
right? So I'm stabilizing here, pushing here. When I do flexion, I'm stabilizing behind when I'm pushing on the head. Stabilizing here, stabilizing here.
I didn't even realize you could
Okay.
do
Yeah.
So, when you were performing the isometric test, right? What if there's pain like upon like slowly releasing?
So what do you think? What reflection do I have to do? Did I allow any aberrant motion? Was there any wiggling in the joint that might be inflamed? Right, so as I let go of the tension, now the joint moves a little bit, it hurts. Right? Or is it muscle? You just have to think about what the finding is. Okay, because those things will happen. So then you have to reflect and say, did I do the test right? Did the patient understand? Student error, typical novice clinician errors are they do, okay, so go ahead, I'm gonna push your head, go ahead and hold it, okay, good, relax. Okay, hold it, and relax. It's sloppy. Trying to be very specific and incriminate specific tissues. So it's gonna be here, hold. Don't let me move you, and now slowly relax. She's easing off, I'm easing off. Then the opposite direction, right?
Yeah.
Hold, and slowly relax. I don't get obsessed about breathing because I'm having my patient talk to me. If you're talking, you're breathing.
I can't think that much.
You start,
Just have to talk.
when you're doing stuff like this, you
It's
start
coming
telling
up.
the patient, okay, I want you to breathe, forget.
Breathe.
They forgot to breathe.
Exhale, inhale.
Okay? Talk to
I
me.
don't think I'll make
Exhale,
breathe in 4
inhale.
And
minutes.
it's not a maximum effort. You're only getting the muscles to contract isometrically from origin to insertion. You're not doing a break test, you're not doing a manual muscle test. Good? Right, so we'll practice that for 6 minutes each.